Hi, Miss Nikki here. Welcome to Chapter 20, Part 1. We're now going to talk about the vessels of the cardiovascular system. So in Chapter 19, we talked about the heart. We're now going to talk about the arterial system, the capillaries, the venous system in Chapter 20. And then in 21, we're going to talk about the lymphatic system. So any really large molecule is going to be picked up by the lymphatic system, cleaned by the lymph nodes before that fluid is returned back to the heart. So basically this is Unit 2. This is how all of these chapters come together to form what some people call the circulatory system. So remember, cardiovascular system and lymphatic system are both separate systems, part of the 11 organ systems that make up the organism, but that sometimes people will take these two systems together and call them circulatory system. It's how fluid is circulated through the body. We should already know these terms: artery, away, right? So blood from the heart to the capillaries, blood away from the heart. Veins are going to be blood back to the heart. So return. And then capillaries are where we're going to exchange substances between blood and tissue. And remember, we do this in two places. So we talked about pulmonary circulation, and we talked about the fact that we're going out to the lungs and we're dropping off CO2 and we're picking up oxygen. And then we also have the systemic circulation. This is at the tissue. Right? We're dropping off oxygen and we're picking up CO2. Now we're going to go through the structure of the vessels. So tunicas are going to be layers. Lumen is the inside space. So you'll usually see a blood vessel. They'll talk about the walls. We're going to go through those layers or tunicas. And then there's this open part in the middle, and this opening is the lumen, and what's going to be flowing through the lumen? Blood. So the tunica intima, this is the innermost layer. It's made up of endothelium. Remember, that is simple squamous epithelium. One layer, squamous shaped cells, of the basic four tissues, it's epithelium. It's going to have something to do with absorbing and secreting, right? So endothelium. There also has to be connective tissue underneath the epithelium, right? There's always connective tissue that has blood vessels because the epithelial tissue is avascular. The middle layer is the tunica media, and this is where we're going to see muscles, so specifically smooth muscles when we're talking about hollow tubes, right? This is where we're going to see vasoconstriction and vasodilation. So you're either going to contract the smooth muscles and narrow the lumen, or you're going to relax and do vasodilation and you're going to widen the lumen. And then there's this tunica externa. This is the outermost layer. It's going to have some connective tissue with elastic, collagen fibers. It's going to act as an anchor. And then we're also going to see vessels inside this tunica externa. They're called vasa vasorum. So it's small arteries that are required to supply the tissue of the very large. So vessels within vessels. So here's a nice visual representation of an artery, a capillary, and a vein. But I also wanted to go back to those tunica layers real quick and let you see that we're always going to have kind of this same setup where we're going to have some sort of fibrous on the outside, then we're going to have some sort of muscle on the middle layer, and then we'll have some sort of internal epithelium layer. So we're going to see this again and again. You always have an anchoring, fibrous, a muscular layer, and then an epithelium layer. So here we can see the lumen of the artery, the opening that the blood would be flowing through. We can see the internal lining, the endothelium, so that tunica intima. It also has to have that sub-endothelial layer that's the connective tissue that's feeding the endothelium. Then you're going to see the tunica media, which is all of this muscle, and we're looking at an artery first. And then you're going to have the tunica externa, and this is where you're going to see the vasa vasorum. So it might be hard to see, but there are vessels within the outer tunica, so vessels within the vessel. So again, the blood that's flowing through the lumen is not going to feed the tissue. It's the vessels that are in this tunica externa. Over here, we can see the lumen, or the opening of the vein, and you can see it's a lot larger. You can also see that veins have valves, and because we're pushing blood up against gravity back to the heart. So we'll talk more about these in the next section. Then you can see there's still muscle here. There's tunica media, but it's a lot less muscle. And then we still have the endothelium lining. You can see here with the capillary, they want to make sure that you can see the artery is coming into the capillary bed, and then the vein is leaving the capillary bed. And we're going to learn terms for these: arterial, which is a smaller than an artery, and then we have a venule, which is smaller than a vein. This capillary bed, you can see here, this internal lining is endothelium. So when we look at different vessel types, they're usually going to lay next to each other. So usually we're going to have an artery and a vein and a nerve running pretty close to each other. They're going to serve the same body region. So we're going to see things like femoral artery, and then we're going to see femoral vein. Arteries have a thicker tunica media. So these are going to be able to do, remember, media was the muscle, so this is going to be able to do vasoconstriction, vasodilation. The outer layer has more elastic and more collagen fibers. Veins have a thicker tunica externa, so that's the fibrous, right? They have a larger lumen, larger opening. They have less elastic, less collagen, and the wall can kind of collapse a little bit if there's no blood in it. So when you see an artery, it's going to have lots of muscle, really thick muscle. It's almost a perfect circle. You can see that this is a thicker wall, but there's really not a lot of muscle there. And sometimes what will happen is they'll have these weird shapes where the top and the bottom will kind of pinch together. So this is more circular, but usually they're a little bit more flabby. You can also see that the lumen, the opening here, is a lot larger than the opening of, or the lumen of the artery. Capillaries are going to have the tunica intima only. They're going to be just one layer of endothelium, right? This thin wall is going to allow for rapid gas exchange. So they're also trying to show you here, if we started at the aorta, you're going to come out and have a really large elastic artery, then you're going to have a muscular artery, then you're going to have an arterial. So hopefully we can see that these are getting smaller and smaller until we actually get to the capillary bed. So you wouldn't want an elastic artery to go straight to the capillary bed because this tissue wouldn't be able to handle that pressure, right? So we're kind of going from a large tube to a medium-sized tube to a smaller tube to actually the capillary bed, where we're going to drop off oxygen, glucose, nutrients. And then on this side, we're going to pick up the waste. You can see there's a venule, then there's small and medium-sized veins, then we get to large veins like the inferior vena cava, superior vena cava, back to the right atrium. Arteries are going to branch into smaller vessels. The lumen's going to decrease, the elastic fibers are going to decrease, and you're going to have less smooth muscle. So these are the three that we just saw in the previous image, and let's talk a little bit more about each one. You can see the elastic arteries. These are the largest of the arteries. Probably the best example is the aorta, pulmonary trunk. They have a large proportion of elastic fibers. They allow for stretch and recoil. These are going to pump blood from the heart to the muscular arteries. You can see muscular arteries are going to distribute blood to specific body regions. This is where we're going to have lots of muscle for vasoconstriction, vasodilation. We're going to have elastic tissue, and they're named pretty much after what area of the body or body region that they're distributing blood. So brachial would be upper arm, right? Coronary artery would be going to the heart. The next we have arterioles. These are the smallest arteries. These are going to have only a thin layer of endothelium, some of the smaller ones, and one single layer of smooth muscle. The smooth muscle stays partially constricted. If you remember, we briefly talked about vasomotor tone when we talked about sympathetic and parasympathetic. So you don't want flabby arteries. They have to be somewhat partially constricted. This is regulated by the brainstem. So systemic blood pressure and blood flow are going to be regulated by these arterioles. We're going to be able to do some vasoconstriction and vasodilation. Just to show you another image here, they're showing you elastic arteries, right? Tons here, elastic fibers. You can see the muscle. You can see the tunica intima. Then we have the muscular arteries. You can see that it's a little bit less. And then here we actually get down to an arteriole. We have the tunica media that has just a few layers of smooth muscle. You can see on this clinical view that we can have plaque buildup. So we can cause the thickening of the tunica intima, that's the internal lining, and that can reduce the amount of lumen or opening, right? So a narrowing of the arterial lumen. Cholesterol in your blood can cause this and prone to forming plaque. Males are affected more than females. Smoking and hypertension increases the overall vascular risk. You can also do angioplasty, which can help expand that narrowed region. They basically put a balloon in and they drag it along the vessel and try to release some of these plaques that are building up. And then we can also do coronary bypass if it happens to be a blockage in the left coronary artery or the right coronary artery or any of the other ones as well. We can do a coronary bypass where we connect directly from, say, the aorta to the bypassing where the blockage is to the vessel that's farther down that would be feeding the ventricle muscle. Sometimes we can have aneurysms where part of the arterial wall is going to thin and balloon out, and these are prone to rupture. This can cause massive bleeding. Obviously, you can imagine if you ruptured your aorta, you're not having enough blood flow to the area, right? So elastic and muscular arteries with age, they're less able to stand those forces. So your blood pressure increases as you get older, and that's pushing on the inside of the muscular and elastic arteries. So basically, as you get older, it's more common to see aorta or arteries at the base of the brain that can have these thinning, ballooning walls that are prone to rupture. Now we move on to capillaries. So we've done the arteries leaving the heart, right? So I'm going to draw my heart here. Arteries leaving. Then we have capillaries, if we're talking about systemic, right? And then back up the veins back to the heart. So we said arteries go to arterioles, and we're finally at the capillary bed. This wall of a capillary is an endothelial layer. It's one layer of simple squamous epithelium. And this thin wall with a small diameter is optimal for the exchange between the blood and the tissue fluid, right? What is this called? What are we trying to do? We're trying to get nutrients into the tissue, right? We talked about perfusion. So we're going to talk about these three different types. So not all capillaries are the same in different areas in the body. You have different capillaries depending on the need. Here we see continuous capillaries. These are probably the most common. These are the ones we're going to see in muscle and skin and lungs and central nervous system. Any sort of large particle, cells or proteins cannot pass. So no large particles, but smaller ones like glucose, oxygen, CO2, these can pass through. There are tight junctions connecting the cells, and there is a continual lining with these endothelial cells. They are made of epithelium, but endothelial cells. So remember, endothelial cells line all the chambers of the heart, and they line all of the blood vessels. So these are the ones we probably most commonly think of, these continuous capillaries. And pay attention here that these are solid. Now we can see with fenestrated capillaries, they have pores in them. So it's still endothelial cells with a continuous lining, but the cells have holes in them, pores in them, and these fenestrations allow for smaller plasma proteins to be able to pass back and forth. So we're going to need this when we talk about intestines, right? So if you're trying to absorb food if you're trying to push the movement of more fluid into an area. Remember, those plasma proteins leak out, and then that determines how much fluid can flow from the blood vessel out into the interstitial fluid, right? So these smaller plasma proteins can get through. We can also absorb nutrients in the intestines. Kind of my example was if you eat a burger, right? You're eating cow, you're taking the muscle, the protein, you're breaking it down into amino acids, and then we're doing absorption of those amino acids, and then we're using them to assemble our own proteins. You can also see how the kidney capillaries might be these fenestrated. So when we're trying to filter blood and we're trying to create urine, the items that we're going to excrete, we have a lot of nitrogenous substances, uric acid, urea, so items that we might want to be able to release via the urine. So we're going to see fenestrated capillaries mostly in the intestines and the kidneys. These sinusoidal capillaries, they're still endothelial cells. They have a lining, but you can see now that they're barely held together, right? They have these really large gaps, large openings, and these are going to allow the transport of really large substances. So things like formed elements, remember that's red blood cells, white blood cells, really large proteins found in bone marrow. Remember, this is hemocytoblasts. Hemocytoblasts live, I forgot the O. Hemocytoblasts are in the red bone marrow. Spleen, we're going to store red blood cells, old aged red blood cells. And then remember the endocrine glands, some of the hormones that we're trying to secrete, they're really large, right? They're peptide, protein based, some are lipid based. So sometimes we need these really large gaps to be able to push from the interstitial fluid back into the capillary to get this, whatever, the hormones or the red blood cells to where they need to go. Next up, they talk about capillary beds and how they function. So they mention this term meta-arterial. So this is a vessel branch of an arteriole. So you can see right here, the meta-arterial. The proximal part is encircled by smooth muscle cells. So we're going to see these pink kind of circles, and we call these sphincters. There's also a channel that goes through, this thoroughfare channel. And then it's going to connect to the venule side. So it's arterial, capillary bed, venule. Arteries coming this way, veins going this way. So true capillaries, you're going to see vessels branching from the meta-arterial. They make up the bulk of the capillary bed. We're going to see these sphincter muscles. They're smooth muscle. And if a sphincter relaxes, it permits blood flow into the true capillary. If we constrict, it basically turns off the blood or allows the blood to bypass the capillary bed. So this is going to happen in a cycle. We're going to see contracting and relaxing of these pre-capillary sphincters. We're not going to see all of the capillary beds open all the time. You're only going to see a portion of them. So this image is showing you the sphincters are contracted. So if the sphincters were open, if these sphincters were open, blood would be flowing all the way out into the true capillary bed. If the sphincters are contracted, we're just having we're just having blood move through the tissue, right, to make sure the tissue stays alive. We still need nutrients. We can't shut it off completely, but we're not pushing blood all the way out. So usually I tell people, think about times that you might not want blood flow, to be pushed out into a certain area. If you're not using that area, there's no reason for you to push blood all the way out into the capillary. You can go ahead and have the sphincters contracted, just move blood right through that thoroughfare so that the tissue is still getting some nutrients, but it's not being pushed all the way out into the capillary bed. So venules, these are the smallest veins. These are going to merge to form veins. We're going to see small and medium-sized veins. Then we're going to see the largest veins. And veins have numerous valves. So we're trying to prevent the blood from pooling in the limbs. Remember, we're trying to push blood against gravity So gravity's pushing down on that blood, and we're trying to get the blood back to the heart. So basically we push blood, and then the valve door closes so that the blood can't drip back down. So we just keep pushing past the valve, and then we push to the next valve. In this image, they want to make sure you understand that the majority of your blood is in your systemic circulation. So when we're at rest, they're saying about 70% of the blood is in your systemic circulation. So majority is in the veins coming back to the heart. Some is in the arteries, some is in the capillaries. You can see that pulmonary circulation is only about 18% and about 12% of your blood is in your heart. So the majority of your blood at rest is in your systemic circulation. So we just said about 55% of your blood is in your systemic veins. They want you to see that that's for a reason, because this blood in your veins, as it's trickling back to the heart, right? We're taking the blood in our veins and it's being pushed back to the heart. Remember, we're having to push past those valves, that this can act as a blood reservoir. If we need to, we can move blood from the veins into circulation via constriction. So if we constrict the veins, we can push the blood faster. We can have more blood needed during exertion. And then blood can be shifted back into the reservoirs of the veins through vasodilation. So when less blood is needed during rest, we can continue to let the blood trickle back to the heart. Now we're going to talk about these different pathways. They want you to realize that it's not simple, right? One of them is called simple pathway, but you'll see in just a moment that there's other pathways. So usually one major artery delivers blood to an organ or region. The artery end is the one that provides the only pathway for blood to reach that organ, and then it's going to branch into smaller arterioles. Each arteriole is going to feed a capillary bed. The capillary bed is drained by a venule. The venule merges into one vein. So we've seen this system already, right? We have artery, large, it's going to narrow to an arteriole. Then we're going to have our capillary bed. Then we're going to have our small venule, and then that's going to open up into a vein, right? So all of that we've already talked about. So they give you an example. The splenic artery delivers blood to the spleen, and the splenic vein drains that organ. So here's the simple pathway, right? One way in, one way out. We just talked about that one. There are some other pathways. You can see here that we have arterial anastomoses. Remember, this is branching, joining together, either branching going out or joining coming back together. So this arterial anastomoses, there's more than one way for blood to get to this capillary bed, but there's only one way out. Then you can have venous anastomoses. There's only one way into the capillary bed, but there's multiple ways for blood to get out of the capillary bed. So we've given you some examples here. Gastric, the superior and inferior epigastric arteries are going to supply the abdominal wall. So there's two different ways for blood to get into the abdominal wall muscles. And then for venous drainage, we'll talk about some of these, the basilic, the brachial, the cephalic veins that are draining the upper limb. So they're coming from an area, multiple branches of venous drainage back to inferior vena cava, or superior vena cava in this case. Sometimes we're also going to have blood transported from an artery directly to a vein. We're going to see this in fingers, toes, palms, basically if that area needs to be bypassed. We're also going to see something called a portal system. So we're going to see capillary beds kind of in sequence. So you're going to see an artery to a capillary bed to a portal vein, back to another capillary bed, back to a vein. We didn't really go into this with the hypophyseal portal system, but that's kind of what we were doing. We're also going to see a portal system when we talk about hepatic. So when we talk about the liver, we're going to talk about the hepatic portal system when we get more to digestion. So sometimes you're moving blood from one area to another area and then diffusing either nutrients in or waste out and then back to the venous drainage. So capillary sole function is to exchange substances. This could be gases like oxygen, carbon dioxide. This could be nutrients like glucose. This can be waste products. We haven't talked about these, but urea, uric acid, breakdown from nucleic acids or proteins. And then we could have hormones, right? We could dump hormones from the endocrine system that we talked about into the blood and surrounding tissues. We want to diffuse it from the blood to the surrounding tissues. So we've talked about diffusion a little bit. Sometimes we can do vesicular transport, and really what we're going to kind of focus on here is bulk flow. So we're talking about fluid movement. And this is the one I keep talking about when I'm talking about blood pushing nutrients and fluid into the interstitial fluid and then having that picked up by the cells. Right, so I think I've talked about this a couple of times. So the blood's going to push the fluid out into the interstitial fluid, and then that fluid's going to be picked up by the tissue or the cells. Before we talk about bulk flow, I just want to go back to diffusion. Hopefully we remember diffusion is passive transport. There is no ATP required, and we're moving something from a high concentration to a low concentration. So if oxygen is high in one area, we're moving it to where the oxygen concentration is lower. So you're moving some sort of non-charged molecule across a gradient from high to low. So oxygen, hormones, nutrients, they're going to move from the blood to the interstitial fluid. Carbon dioxide and waste is going to diffuse from the tissue into the blood via the interstitial fluid, right? We do have some cases where you're going to see vesicular transport, where you're going to see a vessel formed, pinocytosis or exocytosis. So certain hormones, they're too large to be pulled in or out of the capillary bed. So certain hormones, fatty acids, they're going to be picked up and transported by being engulfed in a vesicle. And you can see this is highlighted. This is what we really want to focus on, how fluids flow down a pressure gradient. So large amounts of fluid and dissolved substances are going to move in the direction depending on the net pressure of opposing forces. So it gets really technical. They're going to talk about hydrostatic pressure and colloid pressure. I'm going to come back and show you the image in the next slide, and hopefully it'll make sense. So filtration is when fluid is moving out of the blood. So I keep drawing this kind of image where I have the blood, and then I'm saying you're pushing fluid out into the interstitial fluid, and then it's getting picked up by the cells. Right, well, this wasn't the best image. It was just kind of the one we used in the beginning, because we have an arteriole coming in, then we have our capillary bed, then we have our venule, right? So we have kind of a more complex setup, and in these images, they're going to show you the tissue in the background. But we still have to go capillary bed, interstitial fluid, and then the tissue has to pick up the fluid, right? So here's where we're talking about bulk flow. So filtration is when fluid moves out of the blood and occurs on the arterial end of the capillary, and reabsorption is fluid moving back into the blood on the venous end. We're going to look at the image and talk about hydrostatic pressure, but that's the force exerted by the fluid. So in your blood vessel, we have blood, and blood is mostly water, right? So we have pressure pushing on the inside of the blood vessel. And then out here, we have interstitial fluid, and that fluid is pressing back on the blood vessel. So don't go too much into all of this craziness. Look at this side. Are we going from the heart? Are we on an arteriole? Right? This is where the capillary bed would be. So blood is flowing through that thoroughfare, that meta-arteriole, right? And they're saying that the forces pressing down from the inside are about 35. This is millimeters of mercury. It's how we measure pressure. So 35 from inside the blood vessel pressing down. And then the interstitial fluid, that's all behind the capillary here, the interstitial fluid has a pressure, and that pressure is pushing back on the blood vessel. That's the colloid pressure, osmotic pressure. So basically, if I'm pushing down pressure at 35 and I'm pushing up pressure at 21, what's the difference between those? It's 14, and which one is greater? So basically, who wins? If these are opposing pressures, I've got 35 pressing down and 21 pressing up, the pushing down is greater, so what's going to happen to the fluid on the arterial side of the capillary bed? Any fluid that's in the blood vessel is going to diffuse into the interstitial fluid. On this side, so blood is still moving, right? We don't drop everything off on the arterial side. So blood and fluid is still moving. So now the force pressing down, the hydrostatic pressure is 16, but now the interstitial fluid still at 21 pressing back. So I have 16 pressing down and I have 21 pressing back. That's a difference of 5. In which direction is the number larger? So which way is the fluid going to go? The fluid's going to be pushed into the venule on the venous side. So reabsorption on the venous side, filtration on the arterial side. This is just in words talking about the osmotic pressure. That's the pull on the water due to the presence of proteins. You have interstitial osmotic pressure, and you have osmotic pressure coming from the blood as well. So that's what all these numbers are when they're talking about net hydrostatic pressure versus net osmotic pressure. They're looking at what's happening in the blood versus what's happening in the interstitial fluid. I'm more concerned with the net, right? So you have net pushing out. So you got positive 35 pressing out. You have positive 21 pulling back in. That gives us a net of 14 out. So we're dropping off on the arterial side. On the venule side, you have 16 pressing out. You have 21 pressing back in. That's a net in of 5. So you're picking up on the venule side. So the reason that I'm more concerned about these overall numbers is, do we see any ATP responsible for this? Is there any energy being used? No. Is there any, vesicle picking something up and moving it to the other side, right? So no vesicular transport in this example. And some, we'll see them later when we talk about lipids. But for right now, there's no ATP, there's no vesicular transport. So what is the only thing that's guiding this bulk flow of fluid from the capillaries into the interstitial fluid? It all has to do with pressure gradients. So think about what would happen if the pressure was too high on one end. So if this pressure was extra high, we'd just be pushing out more fluid. What happens if your blood pressure is still really high here? What if this pressure was 35? Hard to write in this little space. 35. So what if the force pressing out was 35 and the force pressing back is still 21? You do not get uptake anymore, right? 35 is greater and it's pushing down. So you're going to dump more fluid, more bulk flow fluid into your interstitial fluid. That could lead to swelling, edema, right? You won't pick up waste. That doesn't sound very good for that tissue, right? So net filtration pressure. At the arterial end, it favors filtration or drop off. And on the venous side, the net filtration favors reabsorption or pickup. So remember, any excess fluid that's not reabsorbed by the venous capillary end, so right here, venous capillary end is, if there's some fluid that's not picked up, and there is about 15%, it's going to enter the lymphatic system and be cleaned by the lymph nodes before we dump it back into the heart. So we're going to kind of set up to talk about how we regulate blood pressure and blood flow. So they want to make sure you realize that local blood flow varies, so not all your capillaries are filled all the time. The amount of blood transported through the vasculature per period of time is equal to cardiac output. So we're going to kind of think of cardiac output, same thing as blood flow. And remember, this is all linked, right? Cardiac output is heart rate times stroke volume, so that has to do with the heart. But we're going to add another layer to this. We're going to say blood flow also has something to do with blood pressure, right? So the pressure pushing inside your vasculature. So that has something to do with the vessels. So can we increase pressure? Can we do vasoconstriction? Can we decrease pressure? That would be vasodilation. And then we're going to add another layer to this, the blood moving through, right? As the blood's moving through the vessel, it's putting pressure on the vessel. So not only can we change the vessel, not only can we speed up or slow down our heart, but your blood is made up mostly of water, right? The plasma, which is the majority, and most of your plasma is water. So the water is controlled by hormones, right? ADH and aldosterone. So we're going to kind of see how all of this comes together to talk about blood pressure in part 2. I'll talk to you guys soon. Bye.